Okay. Starts at UW and is a board certified psychiatrist and palliative medicine physician. She works with individuals experiencing serious persistent mental illness at Harborview Medical Center. Mr. Meeks received his Master of Nursing from the UW in 2014 and is the clinical director for inpatient psychiatry and psychiatric emergency services at Harborview. His primary area of interest is identifying and developing evidence-based interventions to decrease aggressive behavior. Thank you so much for joining us.
Thank you, Alice. I'm just going to get our presentation going here. Just give me one moment. All right, and my hope is that everybody can see the slides now. Maybe Tim, if it's okay, I could maybe.
You know, we cannot.
Oh, I apologize. Let me try again.
That's it.
Thank you. Sorry about that, everyone. Maybe I could go first. Thank you, Alice, for that introduction. Again, I'm Dana Dieringer, and as Alice mentioned, I'm a psychiatrist and palliative medicine provider at Harborview. And yeah, I work with a lot of folks who are experiencing serious persistent mental illness and facing a lot of behavioral and interpersonal challenges. And I'm really excited today to be joined by my colleague, Tim Meeks. I'll let him introduce himself.
Hi, I'm Tim Meeks. I, as you heard, am the clinical director for inpatient psychiatry and the psychiatric emergency services. I've worked at Harborview for, I think, about 14 years. I started as a bedside nurse on the psychiatric ICU. I went straight out of nursing school to work in the psychiatric ICU. It's where most of my, or a lot of my experience working with patients who have psychiatric diagnoses comes from. After that, I went to work in the professional development and nursing excellence department as the clinical nurse educator and then clinical nurse specialist for behavioral health for the medical surgical units. And that's where I met Dana and where we worked together. And then as of the last 2 years, I've been doing the clinical director job. I am a nurse.
Yeah, and I think today we're just really excited to be joining you guys to talking about how we as both as palliative care providers can provide care for individuals who are facing cluster B personality disorders or these types of interpersonal challenges. We have no financial disclosures. Here is essentially the content or the what of the presentation we'll be doing today. We're really hoping you're going to walk away with an understanding of what a personality disorder is and the disparities those with these disorders face. And we're hoping you're going to be leaving with some tools in your toolbox for responding to intense emotions or challenging behaviors, particularly using validation. And then finally, we're going to want you to begin thinking or identifying ways in which you can ask for and give support on your respective palliative care interprofessional teams when working with folks who have personality disorders. This is just to give you a brief overview of the how. This was originally designed to be an interactive workshop, but we're going to be kind of changing that a little bit here for this format. First, together, we're going to be learning together about personality disorders more broadly. And then we're going to pivot into Tim and I demonstrating some skills for you all to observe. And then finally, we'll do some reflecting together at the end. Before launching in though, Tim and I do really want to take an intentional moment together to talk about the importance of recovery and person-centered language. We support not using mental health language as adjectives or as like shorthand for patients. So for example, we encourage saying person with borderline personality disorder instead of borderline patient or that borderline. This is really important given how the language and the history of personality disorders are rooted in historically and today various power structures like sexism, racism, that really do continue to affect healthcare just in general, of course. You're also going to notice today the use of the adjective maladaptive rather than bad or difficult or challenging. Patients with personality disorders face not only incredible healthcare disparities, but really incredible stigma within the healthcare system. And so we just want to be really mindful of that.
All right, so we thought we would take a couple of minutes to talk about what exactly is a personality disorder. The phrase personality disorder is a little problematic itself. It sounds like somebody has a problem with their personality. So we did want to see if we could get you to put some ideas in the chat and tell us what are some of the ways that you would describe someone with a personality disorder. Feel free to throw out a definition of what you think a personality disorder is, and then we will see what you wrote and we'll talk about it.
I can imagine for a lot of folks, it's a pretty complicated definition, and maybe even not something that's super easy to type up and kind of put succinctly into a box.
After we just talked about stigmatizing language, and people are probably afraid. But
that's probably true too.
But doesn't fit social norms. Actually, that is part of the definition I'm going to read in just a second. Different way of thinking or functioning. I would say that is true. Yeah, people have learned different ways of thinking and behaving for sure. So let's go to my mother-in-law. I'll talk about that in just a second. She's unable to understand the emotions of others as separate from her own. We talk about how people with borderline personality disorder relate to others. A lifelong maladaptive way of interacting with others. Okay, it sounds like a lot of people in our group, Dana, have an idea of what a personality disorder is. Let's go to the next slide and talk about that. So we often just will throw around the phrase personality disorder to describe somebody that we're having a difficult interaction with. If somebody's exhibiting challenging behaviors, that person may be described as having a personality disorder when in fact they may not. I noticed that somebody in the chat put something about a relative. Lots of us have family members who have obnoxious personalities. That doesn't necessarily mean they have a personality disorder, or they could. So let's go through the textbook definition. The definition is an enduring pattern of behavior and inner experiences that deviate significantly from the individual's cultural standards or norms, like somebody mentioned, is rigidly pervasive. This is important, has an onset in adolescence or early adulthood. This isn't something that you pop up with in your 60s, is stable through time, leads to unhappiness and impairment, and manifests in at least 2 of the following 4 areas. Cognition, the way you process information, affectivity, mood basically, interpersonal function, or impulse control. So 2 of the 4 of those. Just a little bit of history about the term personality disorder. As I was refreshing for this presentation, I looked this up, and I remembered that it was originally proposed personality disorder, the phrase, in 1938. It's old, but it didn't appear in the Diagnostic and Statistical Manual, or DSM, which is I would say it's the dictionary of psychiatric diagnoses. Is that fair to say, Dana?
Yes.
It first appeared
As
there.
problematic as it is.
Yeah, in 1980. And it described a state between neurosis and psychosis. So it was borderline between those things. We now understand so much more about BPD, and we'll call borderline personality disorder BPD for shorthand during this presentation. I think it's really past time for updates this term. Some are now proposing that a more accurate term would be emotional dysregulation disorder or emotional intensity disorder. These seem to be much more descriptive of what these patients experience. And I hope they renamed the diagnosis in the next version of the DSM, but for today, we're stuck with BPD. There are obviously many domains in life that personality disorders impact, but one that's key for palliative care providers to know and is somewhat consistent across all personality disorders is that interpersonal functioning is often impacted. Having chaotic, unstable relationships is really considered a cardinal symptom of borderline personality disorder. The same could also be said of antisocial personality disorder, which is another cluster B diagnosis.
You know, and to kind of piggyback off what Tim's saying, personality is extremely complex, and for the purposes and scope clearly of our kind of time frame in our lecture today, we're going to be doing a lot of oversimplifying. But suffice it to say, the DSM is trying to offer a common patterns or common constellations of personality that can cause dysfunction for our patients, and it provides this common language in a pretty imperfect way. And like Tim said, there is some kind of exciting stuff coming down the pipeline, hopefully for next iterations of the DSM for helping us care for these patients. Here you can see the vast array of categories of personality disorders that exist within the DSM. And today we're going to be focusing on borderline personality disorder. Though many of the techniques and approaches we're going to be describing today are effective for many of the cluster B personality disorders, particularly antisocial, as Tim has been alluding to as well.
So here we summarize in broad strokes borderline personality disorder. Clinicians will often notice that patients with BPD frantically try to avoid abandonment. There's both this fear of abandonment and this need for engagement that results in this push-pull feeling to interactions. Come here, go away, come here, go away. Connected with this is often an exquisite sensitivity to rejection. Discussions about discharging or changing providers can often trigger instability in patients with borderline personality disorder. Patients often describe a sense of emptiness. Patients with BPD have patterns of instability in a number of domains. Mood lability can often lead to misdiagnosis with bipolar affective disorder. Patients with borderline personality disorder have trouble with impulse control, which can be very disruptive in hospital settings. But I just want to remind everyone that people do what works. If being disruptive has gotten you what you need in the past, that's what you're going to do. Emotion regulation is impaired. Patients with BPD can go from everything's fine to my world is falling apart pretty quickly. Patients with borderline personality disorder are often described as dramatic and attention-seeking. I would argue that rather than attention-seeking, these patients are usually engagement-seeking. They're looking for meaningful connection with others. Patients with borderline personality disorder have trouble with self-image. They often see themselves in relation to others. That was sort of alluded to in the chat. Patterns of instability can manifest in a lot of different ways, but often most notably in terms of their relationships with others. One other area that is an inability to see the grays in the world. Patients often see the world in black and white or in extremes. Situations are tragic or fantastic. People are either good or bad. And lastly, suicidal thoughts and behaviors are common with patients who have borderline personality disorder. This is usually what gets the attention of my team, the psychiatric team, when patients are hospitalized.
Well, let's examine BPD a little closer. In terms of prevalence, it's estimated that 4 to 15% of individuals in the community demonstrate coping styles or personality traits consistent with BPD. And what I want to highlight for palliative care providers is that this prevalence is estimated to be even higher, up to 25%, in individuals who are seeking medical care. There is even like a high heritability for what we know from twin studies, but it can be hard to tease out how much is nurture versus nature, and we're going to get into that just a little bit more here to come. Finally, it used to be thought that women had BPD more frequently than men, but that's actually been not proven accurate kind of with further kind of analysis, and actually is probably a artifact that honestly is rooted in kind of sexist structures. And then finally, up to 40% of patients with BPD are not only underdiagnosed, but misdiagnosed. Diagnosis can be really challenging. And actually, Tim just alluded to this by saying, yeah, a lot of folks with BPD get labeled as having bipolar disorder. Diagnosis is challenging, particularly when we're looking in within hospitals or acute or medicalized settings, because there we're only seeing the patient under right one during high times of stress, but for brief snapshots of time, not very longitudinally.
Really, trauma is often the genesis of borderline personality disorder. And I think this is really important for people who work with patients who have BPD to understand. I think it helps us to have more empathy for these patients, because when I'm working with a patient who has borderline personality disorder, I assume they have a history of childhood trauma. And I'm usually right, because statistics tell us that a huge number of patients with BPD, 90%, have experienced some form of childhood trauma. Patients with BPD frequently describe having a lack of parental affection in childhood, inconsistent emotional validation, and parental behavior that can be described as aversive. As a result of this trauma, it's many patients with BPD, 25 to 55% of them have comorbid PTSD as well. So the role of trauma in the development of personality disorders, BPD in particular, and also antisocial personality disorder, it really can't be overstated, the role.
To further unpack how nature versus nurture is complicated here and likely a false binary, we know from the literature that trauma actually has a lot of biologic impact on the structural development of the brain. So for example, emotional abuse has been shown to be correlated with abnormalities in frontolimbo socio-emotional networks, which then in turn impact emotional regulation, for example. So this is just to kind of further illustrate why patients can experience and express high intensity emotions and have label affects with these trauma experiences, particularly again in childhood when the brain is developing. The good news is that most patients get better. And many of the techniques we employ when working with patients, we want to note, are anchored or rooted to the work of Dr. Marcia Linehan, who developed DBT here at UW, actually. DBT stands for dialectical behavioral therapy. And learning about DBT is like, of course, right, a whole lecture unto itself and a whole other topic. But that said, just to give you a nutshell, the word dialectic is getting at this notion of holding things in opposition, holding things that can be in opposition together at the same time, or how two contrasting notions or feelings can be true at the exact same time. And we've been talking about right already, or alluding to, that for many folks with borderline personality disorder, the world exists in extremes, or one or the other. And so life or people become very black and white, or all good or all bad, like Tim was talking about. So DBT kind of helps individuals with BPD explore the gray and and learn about how extremes, even extreme emotions, can exist simultaneously together. While prognosis on the whole is good and hopeful for BPD, there are still many healthcare disparities, though, that individuals face. Notably, life expectancy is up to 2 decades shorter. And of note, suicide and homicide do not account for all of this shorter life expectancy. We know from the literature that there's higher risks for chronic conditions like heart disease, just as an example, and substance use. And particularly of interest to palliative care providers, these individuals often, it's not just that they're having a harder time accessing care, it's often how are they utilizing that healthcare? It can be challenging for them to be able to utilize healthcare effectively.
Sorry about that. So here are some examples of the unique challenges that patients with borderline personality disorder face at the end of life. In some, a lot is related to the difficulty these patients have forming stable relationships, since so much of the palliative care depends on a stable therapeutic alliance. This can create unique challenges. Being sick and in the hospital can amplify maladaptive coping skills in anyone, but this is especially true of patients with BPD who already face challenges with emotion regulation and distress tolerance. In particular, the maladaptive behaviors that can be so disruptive are easily reinforced in medicalized environments. There are a lot of people around, well-meaning people who are eager to keep the peace and soothe upset emotions and may inadvertently reinforce maladaptive coping skills, maladaptive coping behaviors. Navigating all of these relationships in the hospital is hard for everyone. Dealing with so many providers can lead to inconsistency in messaging. These inconsistencies are very hard for somebody with BPD and can be very destabilizing. And we'll talk about some solutions to that a little bit later. The psychological changes can also be upsetting and make it difficult to access usual healthy coping skills. Patients with BPD in the best of times have difficulty naming their emotions. It is, in fact, an exercise that we will give patients with BPD just to identify what they are feeling and kind of sit with that emotion, name it, and be able to tolerate it. So imagine how hard this could make it when somebody's facing the end of their life if they can't even identify the emotions that they're feeling. Remember when I mentioned the push-pull feeling that you get, that you can get when working with someone with BPD? They'll often want your help, want connection, and at the same time, they're unable to tolerate the help you're offering. This is hard for the patient who so desperately needs help and for the caregiver who wants to give help.
Yeah, Tim, I think you've highlighted that we also, are thinking palliative care, we're often taking care of patients and caregivers. And so you can imagine it's not just healthcare providers that are feeling that push and pull, but it's the caregivers too that are at home with our patients.
Yep.
I think let's maybe take another kind of just stop here for a second, and I'd be curious to kind of see in the chat, now that we've talked a little bit about personality disorders and some of the challenges facing patients, I want to pivot a bit and talk about some of the challenges we as palliative care providers can actually encounter when providing care. I'm wondering if folks can maybe throw some ideas in the chat. Yeah, I'm seeing here social isolation with complex fraught relationships, when actually support's really necessary. You can imagine, as people are facing serious medical illness or at facing the end of life, they need more help oftentimes, just really concretely.
Determining goals
Yeah,
of care can be difficult if
absolutely.
having that therapeutic relationship with the team is hard.
Yeah, and I'm noticing someone highlighting here, and particularly within the frame of withdrawing dialysis, there can be a lot of changing dialysis or a lot of moving, in terms of what is their decision and vacillating between things. And then someone else is identifying just mistrust in the medical system. Absolutely. We've talked about, right, the stigma. Many of our patients have experienced trauma within the medical system itself. Oh yeah, and this is, yeah, impulsive behavior sometimes at odds with stated goals of care. I think we've all been in that situation where a patient tells us, right, that they want something pretty explicitly, yet their behaviors do not line up with that. Like they're not doing PT, they're not doing kind of their nutrition plan, whatever it might be. Those are great. Thank you for putting those in there. I'm gonna keep kind of moving here. So to piggyback kind of off what you guys have just kind of brought up, you know, in palliative care, right, high premium and emphasis is placed on building rapport and trust pretty quickly with the patient. And as some of you guys have identified, right, with folks with BPD, that trust, that rapport, that can vacillate quickly. I think another thing that can come up too is that in palliative care, we often prescribe a lot of controlled substances, which can be challenging for patients who have a hard time discerning physic distress from physical distress and or struggle with substance use issues. So oftentimes folks with personality disorders are prescribed psychotropic medications and well-intentioned attempts at soothing the mood lability, but it's often ineffective. And then oftentimes another thing is that providers can become enmeshed, or they do the opposite and start withdrawing care inappropriately. And then I'm also noticing someone has added to the chat, like, yeah, this can take time, and that is not something the medical system often affords us. And yes, and I'm noticing some questions about diagnosis. We will take a break. I should have noted at the beginning that we'll take breaks to answer questions throughout the presentation, and you're bringing up some really great points about how even do we diagnose personality disorders, and how do we understand those prevalence rates and the intersection of racism with that. So many of the challenges that we've been discussing that we as providers can face are really often linked to the emotions, often unconscious, that are naturally arising within us when we're interacting with patients. And in the mental health world, we call these emotional responses countertransference. And there are a lot of different ways emotions can manifest. They can range from feelings of, hey, I want to save this person, to feelings of anger. As an example, like part of my job as a palliative care physician and psychiatrist, I mean, there's times when patients become upset because I'm putting boundaries on what I'm prescribing them. For example, on opioids or stimulants. I've been told I'm heartless or stupid. And when those kinds of conversations come up, they often invoke in me a sense of shame and anger. Anger because the patient isn't seeing how desperate I am to help. And then shame because I'm afraid that, like, hey, maybe I am being uncompassionate, and making me kind of question myself. The shame and that anger can then translate to me being defensive with the patient, and me basically doing like kind of like a but like, and trying to prove myself to them and prove that I'm a good doctor, essentially, that I am effective. So monitoring and being mindful of countertransference is essential. And finally, I just want to highlight that unfortunately, like just like our patients with borderline personality disorder, we as healthcare providers are not often taught or even modeled how we should identify our emotions and how we should be expressing our emotions and doing that kind of complicated interpersonal communication skills. Our internal emotional experiences, and I'm sure this isn't surprising to anyone, can contribute to burnout. And burnout, we know, is a super complex topic, right? Hits on a lot of domains, but part of that experience is a sense of being unable to draw meaning or energy from work. It can manifest in the 3 domains I have listed in the slide. And we know, like in medicine as a whole, up to 48% of physicians report burnout in survey studies. And here I'm showing actually a table from a survey of interprofessional palliative care providers. And here you can see burnout rates across healthcare providers is 38%, but I do want to highlight that rates are often higher in non-physician groups, however. And then when we're looking at specific domains, about 34% of palliative care clinicians report emotional exhaustion. And so understanding countertransference and having ways of coping with these intense emotions isn't just good for our patients, it also can be good for us. going to take a second here to just say that we're going to be now transitioning into a different kind of section about like, hey, what do we do about all this? What are some techniques maybe we can try? Before I do that, I want to, I believe it was Claire who had brought up some questions about like, hey, these rates of borderline personality disorder seem pretty high. And you're exactly right. I think that actually the evidence or the literature on this is pretty mixed. And you'll notice there's a huge range of like what's estimated to be the prevalence of borderline personality disorder. And unfortunately, because of racism, sexism, and a lot of other kind of structural inequities within psychiatry, it's been a moving target and really problematically diagnosed in the past and still today. So it is a bit loaded. I do want to like say that with a grain of salt. There is also evidence about, I don't know off the top of my head, but there is kind of literature that exists about kind of how folks are misdiagnosed with different psychiatric illnesses, including personality disorders based on racism, for example. And then I'm noticing a tip from Renee to everyone, a book, See When Professionals Weep, Emotional and Countertransference Issues in Palliative Care and End-of-Life Care. Great tip.
Sorry, I have to close my chat window. I was too busy reading the chats. So let's learn some ways to interact with patients when emotions are intense or high. So empathic reflections are a great way to validate somebody's distress and bring the temperature down in the room, for lack of a better word. Validation to me is the verbal equivalent of a warm blanket. I've done a lot of de-escalation in my career, and it's really a rare occasion when validation doesn't work. It's not 100% of the time, but it's pretty close. It's very difficult to be upset with somebody who is listening to you, saying that they hear and see you and is agreeing with your perspective, or agreeing with your experience, I should say. The key in validating is really making your tone genuine, reflecting back to the patient what you heard them say so that they know that you heard them. Really using active listening skills. I do want to have one caution, and Dana was talking a little bit about some interactions that she had that were difficult for her, and described a patient who was sort of attacking her or accusing her of not caring. And our default when we're challenged is often to defend ourselves. And, you know, when someone says, you don't care about me, or you're just here for a paycheck, we have a tendency to say, I do care about you. Of course I care about you. But if you think about that, there really isn't a more invalidating statement, because the person just said how they felt, and you said, no, you're wrong, I do care about you. So a validating response to that would be, you feel like I don't care about you. So reflecting back to the person what they just said to you, it sounds like I need to do a better job of showing that I care. That is a validating statement. Look for opportunities to let the person know that you understand the emotion that they're feeling. If they're sad or angry or frustrated, let them know that you see that. It's important that you do this with authenticity and with a demeanor that role models the behavior that you would like to see, because people will mirror you often. You should be calm, composed. I usually tell people laid back, and emotionally somewhere between warm and neutral. There's an example on the slide of validating with reflection. If somebody says, it really pisses me off when you just waltz in here like that without asking. Empathic reflecting is, you're angry, I didn't ask permission to enter your room. You're just reflecting what the person said. I encourage you to take the fundamentals of what we're suggesting and try it, make it ring true for you, because what I use for validating is not the same as what Dana uses. So really try to find something that works for you. It should sound like you when you say it. If you're ever lucky enough to receive training in dialectical behavior therapy, we offer a great training course at UW. You'll learn all about and but statements. Here is our attempt at a condensed version of that training. So what do I mean about and statements? Dana touched on dialectics earlier and explained that it's holding two things seemingly in opposition at the same time as both true. That is a challenge for patients with borderline personality disorder because, as I said, they see the world in black and white often. So we need to make sure that our language supports dialectical thinking. This and that can be true. But statements are ultimately invalidating and don't support dialectical thinking. When you add the but in a statement, what you're really saying is, what I said before isn't important. Everything after the but part is what I want you to listen to. It's not a dialectical way of thinking or speaking. So think about this scenario. You're caring for somebody who wants more opiates. You feel it's unsafe to prescribe more. Have any of you ever been in that position before? Dana has.
I was going to say, I think a lot of folks, or maybe from the nursing perspective, asking, right, like, hey, can you bring me a PRN? Or, hey, like, I need, something along those lines.
So here are two ways that you could communicate your concerns to somebody. I understand you want more opiates for your pain, but I can't prescribe anymore. When you say that, all the person hears is, I can't prescribe anymore. Or you can say, I understand you want more opiates for your pain, and I can't prescribe anymore. You're saying both of these things are true, that I'm hearing what you're saying, and I can't do that. I understand you're having challenges with pain control, and I'm afraid of prescribing more opiates. It almost begs to open up a conversation about other things you can do for pain control. Here's another way you could say the same thing. I care about making your pain level manageable, and I can't prescribe more opiates. Or I care about making your pain level manageable. No, the first one was, but I can't prescribe more opiates. Or I care about making your pain level manageable, and I can't prescribe more opiates. Those two things that can seem in opposition at first, somebody saying they're not going to give you more opiates, but they're also saying, I care about your pain control. So the difference is subtle, but I think it's meaningful. Try it. It takes a little practice, but eventually you'll see the benefit of and statements.
We're now going to move into a demonstration for you guys rooted in a case.
All right, so our goal here is to show you some empathic reflection, some validation, maybe an and statement or two, and role model and interaction that could be challenging for many of us. So you're a nurse working on an inpatient hospice service. Dana is a 36-year-old woman with metastatic colon cancer, admitted 3 days ago related to intractable vomiting and a pain crisis that have since improved. From a medical perspective, Dana could be discharged back to her apartment with her regular routine home hospice care. She's also refusing to leave the hospice facility and speak with various social work members of the hospice team. Her prognosis is estimated to be on the order of weeks to months. While a safe disposition plan is being built, you are her nurse for the second day in a row. You've noticed how she does not attend or help with her colostomy bag, a task that she is capable of doing. She's been calling for help every 15 to 30 minutes for things like medication, snacks, help arranging pillows, and other similar care needs. So Dana is now using the call system, demanding the nurse change her ostomy bag. Hi, Dana. I'm Tim. I'm your nurse. I hear you're having some difficulties today with your colostomy bag. How can I help you?
Well, first off, I want to be called Miss Dieringer. And second of all, I need you to change my sheets and this colostomy bag. The nurse last night did it for me, and you idiots haven't done anything for me today.
I can see that you're upset, Miss Dieringer. You're right. I should have asked how you preferred to be addressed. My apologies.
Sure, but what about my bag and my sheets? I want a different nurse. I'm tired of being left hanging.
Being in the hospital and having to wait is hard, and I can see you're frustrated.
Yeah, I'm pissed off. Are you going to do this for me and fix it?
Yes, I can help you with that. I know you want me to change your colostomy bag, and I need you to help me I need you to help me and show me what works for you. I'll go get some supplies and we can work on this together.
Fine.
Doing this by yourself is hard, and I appreciate your willingness to work with me. So I hope everybody was able to hear and was able to see my dialectical thinking. I hear what you're saying, and I want you to help me. I tried to do lots of verbal warm blankets by agreeing with Dana and validating her concerns to try to calm the situation.
Yeah, and I just want to highlight too that, like, notice we weren't best friends at the end of it. But I was kind of you were addressing Tim each kind of concern that I had as we moved through, and I kind of couldn't really argue effectively, and we ended up working towards the thing that needs to happen. Me working on my colostomy bag with you to help facilitate the discharge.
And I tried not to take the bait. I just kind of let the comment about idiots roll off my back. And when you asked for a different nurse, I just sort of kept on going to see if we could come to some sort of an understanding, which we did.
All right. Just want to take a break there for a second to see if there's any questions before we move into the final piece of today's lecture. I'm not noticing anything in the chat. So I guess in the interest of time, what I might do is just have us move into that part. Basically, we'd like to invite you guys to start reflecting a little bit about the ways in which palliative care team members can provide support to one another when we're caring for individuals with personality disorders. And I guess maybe if folks wouldn't mind maybe putting some ideas into the chat, but how can we kind of as a team come together and be there for each other? Validate their emotions and feelings. Absolutely. So, we've been talking about how to care for individuals with borderline personality disorder, right? And a lot of the same tools still apply to how we care for one another. Safe space to share struggles. Absolutely. Talking about that. Great. All right, well, I'm gonna, if any other folks have ideas, feel free to put it in the chat. I'm gonna move us to the next slide so we could talk about some tactics there. So one kind of way of approaching eliciting and giving support within a palliative care team is first kind of maybe identifying what you're looking for, or maybe what is your colleague looking for? Are they looking for validation? Are they struggling with their own emotions? Are they looking for someone to actively listen to them? Or maybe they're looking for someone to brainstorm with how they can change their approach, or how they can make a change in the treatment plan. And of course, this is a bit of a false binary again, but as we all know, it can be frustrating when you're looking for validation and someone's trying to problem solve or give you advice for it in that moment, or vice versa. And as just a side note, again, this is often sometimes what our patients are experiencing too, when they're telling us their emotions and we're trying to fix it or problem solve it with them.
So let's talk about the emotional support first. So managing emotions, and this includes countertransference. So the first thing is just naming the emotions. Just like our patients, sometimes we struggle to understand our own experiences. So just being able to identify or name the emotion, and then think, how is the emotion impacting us and the care we're giving? Also figuring out if this is really about me. When we're managing emotions, we're frequently taking things that patients have said personally, but really, is it about us? Usually it's not. It's about the patient's frustration, fear, shame, guilt. And also, what are the different emotions that team members are having? Are people having similar or different feelings and experiences? And lastly, is there someone on the team who this is affecting more than others? Is there is evidence that non-physician providers, as Dana mentioned earlier, experiencing burnout at higher rates than physicians. So it's important to understand how different team members might feel differently towards a patient. And then, so there's the emotional part and then the problem-solving part. And when caring for patients with BPD, we mentioned earlier that really consistency is key. And remember, inconsistency can really be destabilizing for patients with borderline personality disorder. So number one, that consistency, it does not mean all the work necessarily falls to one person. People can take breaks and trade off, but having a point person can be really helpful. And remember, demeanor is really important. That laid back, unflappable demeanor works really well when communicating with patients who have BPD. Make sure that all of the teams caring for the patient and even members of the palliative care team are all on the same page. It's often helpful to assemble a care conference when you've got a lot of different providers who are all providing care, just to make sure that we're delivering a consistent message. You can schedule meetings to increase predictability. And you also should reward the patient for positive or neutral interpersonal interactions. In my experience, for most patients, positive reinforcer is engagement. Most of our patients want connection, so spending a little bit of time with them, talking about non-hospital related, non-illness related topics is really reinforcing. And then sometimes you need to phone a friend, and consultation with a third party is helpful. Help doesn't necessarily need to be psychiatry or psychology because this patient has BPD, but discussing challenging, emotionally intense cases with somebody else to get a more objective opinion can be valuable. I know that in my former role as the behavioral health CNS, I would frequently consult spiritual care to see if they may have a role in helping with the patient. I know they're often part of palliative care teams. I might even talk to wound care to see if they had some sort of novel approach for a really complex wound that somebody was having difficulty with. So I really encourage you to make use of resources that you have to support your team and the patient.
You know, in summary, sorry, I apologize here. My screen has been blocked off. So in summary, apologies. I know you guys can read it up on the screen here, but folks with cluster B personality traits or disorders face incredible stigma, health inequities, and comorbidities. And like we said, they're doing the best they can, and they're doing what works for them. And we want to be able to kind of honor both of those things at the same time. Palliative care faces unique challenges in working with this patient population. And we've learned about how empathic reflections and these "and" statements can help palliative care clinicians validate, de-escalate, and model effective communication skills. Finally, we want to provide interprofessional support to clinicians caring for individuals with personality disorders. This is really essential, particularly in terms of managing countertransference and ensuring that there's cohesion and everyone's working together on the same page. With that, that's our presentation for today. I'm not sure that we have time for questions. My suspicion is maybe not. I'll defer to Alice there, but if there is, we'd be happy to make ourselves available for that. Thank you all so much.
Yes, thank you. Alice, do we have any time to take any questions, or are we out of time?
You guys have about 7 minutes for questions. Feel
Okay.
free to unmute yourself and ask in the chat box. Thank you. That was a great talk.
Thank you.
One thing I might add that I've found really helpful, and I know, Tim, I find you really valuable as a colleague on the inpatient units, is that when something does happen, or maybe a hurtful comment is made, or I'm kind of struggling emotionally, is that it's just named, like, hey, as your colleague, I saw that that happened, you know, and I recognize I can't fix it, but it wasn't right. And I, you know, I stand by you. Those kinds of statements can be really helpful.
Yeah, thanks for bringing that up, because I talked about letting things roll off your back, and I think you can do both things. I think that you can, you know, try to not take things personally, and when hurtful things are said, you know, check in with your team members to make sure that they're okay. That's a dialectic.
Mm-hmm. And I think something that we're often teaching our medical and nursing students on our psychiatry units is that dialectic of like, hey, how do we work with patients when there are hurtful things kind of going on? One other thing I just wanted to highlight is that most of our kind of talk today, you notice, was probably, it is kind of geared for medical settings, but I hope that some of these tips could even be translated to outpatient as well.
Yeah, and Claire is asking if some of these strategies can apply to anyone, and yes, they can. Thank you for noticing that. They're really generalizable to anyone, because, you know, as we mentioned, when patients are in, any patients in the hospital, you know, it's one of the worst days of their life. They're under stress, and they don't really have their usual coping skills at their fingertips at those times. So yeah, you can use it with any patients, not just patients with personality disorders. I use validation in all areas of my life. It's really helpful to calm situations down.
Yeah, my husband can even pick up on it now sometimes when I statement him. And I've told him even for his, like, just like managing kind of in his work life, kind of like how to manage conflict. So, but I do think, even though it seems obvious and it applies to everyone, when our own encounter transference or our own emotions are really high, it makes us, though, right, like the things that seem obvious or those like really good clinician tools that we lean on, it can be harder to access. When I'm feeling angry, I have a harder time validating. So that means I have to make it all the more intentional and all the more kind of mindful in that moment.
And I think that we'd also be remiss if we didn't mention that the last year and a half has put stressors on us all. And I think that all of us have a harder time accessing our usual coping skills, or have over the last year and a half.
Oh, we have a really good question here, Tim. Maybe you want to handle that one. Is it ever appropriate to identify boundaries for people who have BPD, such as explaining abusive language is not appropriate when talking with staff, or setting appointment time limits? Yes.
Yes. So it is, and how you set those boundaries is going to depend on who you are. What is tolerable for me may not be tolerable for someone else. But if somebody is so for instance, for me, if somebody is using abusive language, offensive language, one way that I can set a boundary is just by saying, hey, you seem really upset. I'm going to go for about 5 minutes, and I'll come back when you're feeling better. And then just walk out of the room. And what I'm doing is, first of all, the quickest way to extinguish a behavior is by ignoring it. So that whole interaction I just had with somebody, I didn't say, that's inappropriate, or you can't talk to me like that. And the reason that I don't do that is because I know the person knows that. So I'm not giving them any news. But what I'm doing is I'm removing that engagement by saying, I'm leaving, and I'm going to be back when you feel better. And then when I come back, I'm going to reinforce if there's socially acceptable behavior, I'm going to immediately say, hey, things seem to be much better right now. Thank you. What can I get for you? And immediately start trying to fulfill somebody's needs so that I can reinforce that more socially acceptable behavior.
If I could just maybe address the time thing really quick, one thing that I will often use with patients is that and statement there. So let's say you're needing to say, hey, I have 50 minutes and that's it. And that's our time. It's really, like I'll often say to patients, it's really hard to end. And our time is up for today. I'm going to see you at this next time. So that kind of saying that those two things are true at once. Our patients want more of us, and the time is up. And that can be hard.
And let me just throw something in about the setting boundaries again. And for some people saying that setting firmer boundaries and saying, that kind of a language is offensive, I'm going to leave, that's fine too. It's whatever works for you. For me, I just find that leaving works better, but you can absolutely set firmer boundaries if that's more comfortable for you.
Yeah, I think the key is however you're doing it is just not doing more engagement, right? Like you're saying, Tim, is not accidentally rewarding the behavior, just being firm, clear, and using those and statements. Another example I have is this: I just had a family who was paging us at they've got a hold of our pager number at in the wee hours of the morning, trying to get in touch with us. And so I had to set a boundary and say, you love your loved one who's under our care. You're an advocate for them. And the way that you can contact me that we're going to communicate is by doing this. And just being really clear, I've noticed you've been doing this. Here's how you can contact me. And just being really clear, and then not responding to the other behavior, to the other behavior as an example.
And then when they call you the right way,
yes,
really
you have to yep, this is great. I'm happy to talk to you. Yes, we need to always be really reinforcing the other way.
It looks like we're out of time.
Oh, yep, sorry.
That's okay.
Thank you so much, you two.
Take care, everyone. Thank you.
Right. Thanks. Bye.
All right, everyone. Let us move on to the next talk. Our next speakers are Jormain, Cady, Noelle, Lalario, and Lorraine Leist from Swedish Medical Center. Ms. Cady completed a master's in nursing from UCSF and a doctor of nursing practice degree from the UW in 2009. Palliative and supportive care have been a long-time clinical interest, and she joined the inpatient palliative care team at Swedish in 2019, where she currently works as an inpatient palliative care provider. Ms. Lalario works as an ambulatory palliative care social worker and behavioral health specialist with Swedish. She received her master's in social work from the UW and is certified in hospice and palliative care through the National Association of Social Workers. Prior to her work in palliative care, Noelle worked for 14 years as a hospice social worker at Providence. Reverend Leist is currently a board-certified chaplain at Swedish. She received her MDiv from ILIF School of Theology, where she is currently a Doctor of Ministry candidate. She has worked in hospital chaplaincy for over 10 years and is passionate about spiritual care for people living with serious illness. Thank you so much for joining us. And I will hand it over to you. Feel free to share your presentation.
Thank you.
Thank you. I'm just waiting to see our slides. There we go. Okay. Are we ready? So my name is Jormain Cady. I'm a nurse practitioner. I work with our inpatient palliative care team here at Swedish, and I am really excited about being here today and being able to have an opportunity to present with my amazing colleagues, Reverend Lorraine Leist, who's a spiritual care provider with our team, as well as Noelle Lalario, a social worker with us. And I would like to thank Alice and Cambia for allowing us to be here today. We're really excited about being able to present, and also just wanted to thank everybody else who is joining in, just for taking your time this afternoon to come and listen to our session. I was hoping if I could, we're going to be talking about total pain from a transdisciplinary perspective today. I was hoping if I could, if you could indulge me just a little bit, to take a moment to reflect a little bit before we get started. Treating pain is hard. And I think sometimes even in the best of situations, when things are controlled, pain management can be complicated and challenging. And I think we've all had those situations where we walk into a room and it just really feels overwhelming, and it can almost feel sometimes like pain is just sort of spilling over and affecting everything, and that these situations can feel impossibly complex sometimes. And so if we could just take a moment and kind of think about things that might be challenges. I certainly know I have my challenges, but think about things that might be challenges about pain management for you. And if you have, I'd like to invite you, if you have had experiences in the past, I think we all have those cases that sometimes kind of stick with us. We're going to be presenting our own case study, but if you have those cases as well that kind of stick with you, to reflect on whether it's something that's happened recently or, you know, something that's just kind of in your bones back there, be thinking about those as we're moving forward with this presentation, and reflecting as we're moving forward as well. So with that, we none of us have any disclosures. I'd like to introduce, if I could, just a little bit about our system. I joined the palliative care team at Swedish about 2 years ago. I am new to palliative care and felt really fortunate to have the opportunity to join the team during a period of really pretty profound growth and expansion. And so our teams are rapidly increasing. It's been really exciting to see. Right now we have 4 inpatient teams. I work at Cherry Hill. We also have teams at Cherry Hill, Edmonds, and newly to be starting up in Issaquah. And we have 2 ambulatory palliative care clinics as well at First Hill and Edmonds, and we hope to be expanding there as well. And I just have to say, joining a system that really sort of espouses the work we do and is committed to growing and develop that is been an amazing opportunity, and it's exciting to be part of that. That they recognize the value that we're offering to both the patient care as well as to the system, and supporting that in practice by supporting our expansion and growth. It's really been lovely to see. So our objectives today, to describe the concept of total pain and total pain theory. We'd like to discuss some strategies for assessment of the multiple domains of total pain from a transdisciplinary perspective. We'd like to talk a little bit about just distinguishing what are some of the benefits of actually having an interdisciplinary consult service rather than a single discipline palliative care consult. And finally, to recognize the importance of transdisciplinary communication, the need for role definition and flexible role boundaries, shared goals and values, and importantly, trust on a palliative care service. So, talking a little bit about total pain. I'd like to start, if I could, just by talking about some definitions. Pain, distress, and suffering, We often use these terms interchangeably. They have distinct definitions and often overlapping elements in the context of total pain. They are bidirectional, so influences in one they are influenced and can be influenced by others. The International Association for the Study of Pain defines pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. So essentially, on the one hand, the sensory end product of nociception, or the realization or awareness of pain signals from tissue injury arriving to the cortex. And yet, on the other hand, we also recognize that pain can't always be defined by the actual extent of tissue damage that we can identify. And we recognize that it's a subjective perspective. Pain is what the person says it is. I recently ran across people and families experience pain, not nerve endings. So we recognize that it's a multidimensional phenomenon with sensory, emotional, and cognitive inputs. And there are theories of pain that support this, gate control theory, neuromatrix theory, which articulate that ascending sensory pathways can be modulated by descending pathways from the brain to influence our pain perception. And this provides a construct or a context for understanding that biologic, psychologic, and social domains can all upregulate or downregulate our pain perception, the pain experience, and pain expression. So distress is defined as an unpleasant experience of a mental, physical, or social or spiritual nature. It can have many sources, not necessarily just physical, and we often consider it to be temporary. Whereas suffering is described as a perceived threat or damage to the integrity of self, physical or psychosocial. It's inherently emotional and unpleasant. There can be a sense of perceived helplessness or loss. And we often recognize that this is more of an enduring psychologic state and not just transient or fleeting. And so it's important to recognize that suffering really can be in the eye of the beholder, and that depending on the meaning we attribute to a person attributes to a situation, or the coping or the resources that they have, an adverse situation can sometimes be experienced as a challenge, or sometimes even exhilarating. If we think about marathon runners or people that climb mountains, that to other people that don't have those resources might perceive as with more of a sense of anguish, particularly if they're feeling overwhelmed or feeling out of control. So Dame Cicely Saunders recognized these qualities when she developed her concept of total pain. She was a nurse, a social worker, a physician. She studied philosophy and politics at Oxford. She was basically a walking palliative care and hospice team all in of herself. And we broadly recognize her as being the founder of the modern day hospice movement. She described herself as a doctor who isn't in a hurry. And her work paralleled that of Bonica and others, leading to development of multidisciplinary approaches to chronic pain management, but was specific to the unique issues of people at end of life. And so her concept emerged from listening to patients and recording them talking about their experiences with pain. She did extensive narrative research, and her writings spoke to the complexity of managing pain when sometimes patients themselves can't even really articulate or recognize what the sources of their pain are, where the pain is coming from, and sometimes maybe don't even have an awareness that there could be other contributors that are factoring into their pain experience. And this is sort of exemplified by a quote from one of her patients from her writing: "The pain began in my back, but now it seems that all of me is wrong." So while we recognize that multidisciplinary palliative care teams are associated with improved pain outcomes, just given the broad nature of the challenges encountered and the scope of things we encounter, articulating or defining specific interventions can sometimes be difficult. And challenges to this, both in research as well as clinical practice, are that total pain domains are often inherently subjective. They can be of an impractically large scope beyond anything that we can easily measure or come up with practical interventions for. They can be reliant on interviews and detailed assessments during periods of time when patients are sick, they're distressed, they're decompensated, and they're not able to fully engage. And they can be difficult to study longitudinally just due to the nature of the patient population. And so I think it's important to recognize the competing demands as well of the increasing complexity of our healthcare systems that rely on efficient use of resources and are increasingly task-based, particularly when sometimes our interventions may be more narrative in nature and just what that means. And also to recognize and acknowledge the role of clinician vulnerability, and that and the difficulty there can be in bearing witness to our patient's suffering, and just the sense of helplessness that sometimes can come along with that as well.
So what is total pain? Total pain is a holistic experience in which pain from multiple dimensions is happening all together. The physical, the psychological, the social, and the spiritual are all felt as a whole overwhelming experience that's unique to the individual. And it's characterized by a person's inability to distinguish among the types of pain. Total pain is felt on a continuum of serious illness from diagnosis all the way through the end of life. And the concept of total pain is sometimes connected to the concept of total suffering, which is understood as both pain and other forms of suffering. Pain extending beyond physical sensations to involve spiritual, psychological, and social domains threatens the integrity of the individual, which really is suffering. Therefore, total pain is a set of circumstances. In other words, it's a situation rather than just a single event. And according to Saunders, it's more likely to occur when individuals report pain as being overwhelming, out of control, without meaning, where the cause is unknown, and without end. Total pain is this iceberg represents the experience of total pain, where a provider or any clinician that's assessing for pain, where the experience of pain presents, the physical symptoms are what is presented on the surface. Psychological, social, and spiritual distress may be under the surface. So discovering total pain requires looking below the surface to determine what other dimensions of a person's life are affected, and what is actually contributing to the total pain experience. This diagram represents the indivisibility of the separate dimensions of the total pain experience. Total pain actually encompasses physical, psychological, social, and spiritual pain, even as the individual domains actually relate to one another. The authors of this diagram offer this quote: "Pain is considered a complex perceptual and affective experience determined by attention, anxiety, suggestion, and other psychological variables. past pain experience, the meaning of each stimulus, the state of mind of the person at the moment of pain, and sensory nerve patterns evoked in the pain stimulation. And that's the picture of the total pain experience. But now we'll address how total pain can be addressed and effectively assessed by a transdisciplinary palliative care team.
So I guess the first question is, what is transdisciplinarity? And how many times did I need to say that over and over to be able to pronounce it right the first time? Many. So we get our definition from Patricia Rosenfield, who did a lot of work on defining and differentiating between inter, multi, and transdisciplinarity. She says that a transdisciplinary team is a group from different fields that not only work closely together on a common problem over an extended period, but also create a shared conceptual model of the problem that integrate and transcends each of their separate disciplinary perspectives. So how does this work for us? Next slide, please. Thank you. So some of the goals of this, of our team using this transdisciplinary model is looking at getting skill and knowledge from each team member and using that, being able to collaborate with each other, communicate, coordinate, really working very closely together with all of our different skill levels. The team model that we have is also a shared responsibility. So it's not just the medical provider who is in charge of the patient and all the other team members kind of line up as needed. The team that gets built is really sharing responsibility for the patient from when the palliative care consult is made until they discharge from the hospital or leave the team. And within that, there's fluid leadership. So depending on what we're noticing with the patient and family and what is happening, different people might take point on communicating, providing support, facilitating the meetings and those sorts of things. It gives a more flexible approach to team management. And then just a little disclaimer, this is not a standardized, there's not been a lot of research done. There's a lot of room for more research on this particular model. But so our particular team, just to have a sense of where we're coming from, our inpatient team has a medical provider, a social worker, and a spiritual care provider, and that makes up the team. Those are the three folks that come to the assessment, and then from there move forward with what is needed as they get to know the patient and family. And then within our ambulatory clinic, we also have a shared model. So we have a medical provider and a social worker working together to see all the patients. We're fortunate enough to be able to pull in spiritual care as we need it from our hospital settings for folks that are having particular spiritual distress. And so we have a very defined team process that incorporates a lot of these goals of the transdisciplinary team. So for example, we have kind of four processes throughout our day, our morning rounding, and then before going into the visit with the patient, we do a pre-visit strategizing. At each visit, as we enter the room and are starting to get to know what's happening, there needs to be a lot of fluidity around what we call like who's up. So as we start kind of asking questions and connecting with the patient and family, we start to really get an understanding of what is the kind of primary distress or issue or concern for the patient. And we have that team model so that that person they're more in their domain can step up and do most of the facilitating, where then the rest of us step back as more observant. And then after the visit, we have our post-visit debrief, and to be able to really support each other and give each other our assessment using our knowledge and skills based on our discipline to be able to provide a more thorough and robust assessment of what's happening with the patient and their family.
Okay, so moving on into our case study, I'd first like to give the disclaimer. This case study is loosely based on an actual case that our team was involved with in the past. We've tried to keep, I think, our clinical hold our clinical processes as much as possible in terms of our process, interventions and how we approach the patient. But in terms of the clinical details, of course, all identifying patient information, and much of the social and medical information has been modified a bit. Both for patient confidentiality, of course, as well as just to make this a little more general in terms of for illustrative purposes as a case study rather than to be specific. So anyway, moving on. This is a 57-year-old woman with a history of stage 4 colon cancer and peritoneal carcinomatosis. She'd been diagnosed a few years ago and had undergone extensive prior therapy, and more recently had demonstrated evidence of some progression, which prompted a change to the next line of a systemic therapy regimen. Her pain had been previously fairly well controlled with morphine elixir PRN, and given the extent and the burden of disease that she had, her requirement was fairly minimal. Considering that she had no concern in terms of prior opioid use or substance use. There were no red flags around that in her history. And she'd been developing recurrent small bowel obstructions, unfortunately, with repeated admissions over the prior month or two prior to this admission. And then more recently had been having increasing, decline in intake and increasing obstructive symptoms that were really starting to become problematic for her. So she was admitted to the hospital, and she was taken to the OR for an attempt at debulking procedure. Unfortunately, due to the extent of disease, it really wasn't amenable to surgical intervention, and the procedure was aborted. Intraoperative findings described multiple obstructing and partially obstructing masses really throughout her abdomen, and she underwent placement of a venting G tube. Palliative care consult was then requested for pain management support and goals of care. So while we talk about the multiple dimensions of total pain as being indivisible and the sum of many domains, for the purposes of this case study, we will be trying to tease these domains apart a little bit and breaking them down into their elemental components so we can each address them by our discipline. And so starting with her physical pain, when I first met her, she was visibly uncomfortable and clearly anxious. And she had multiple physical complaints, as you can see by the slide. But she had multiple physical complaints, but her primary complaint was that of abdominal pain. And she had more than one type of abdominal pain. She had both visceral and somatic pain related both to the disease burden she had, the extent of disease, distension, and the obstructive issues that were going on. But she also had postoperative pain from her recent surgery, as well as discomfort around her newly placed G-tube site. And she commented specifically that she had been experiencing increasing anxiety and distress since the time of her surgery, and being told what the surgical findings were, and worried about disease progression, and worried about all of the things that would that meant for her moving forward in the future. Additionally, she was having a little bit of confusion. She was having some hallucinations that were felt likely related to her pain regimen. She had both constant as well as incident pain, and her heightened sense of her heightened emotional state, I think for me was really exemplified by asking her about what makes your pain better, what makes your pain worse, and her response was that her abdominal pain is worse when she cries. So looking at her pain regimen, she had both poorly controlled pain, as well as some concern of mild opioid-induced neurotoxicity. And so my first goals with her really were to get her physical symptoms, decreases distress from her physical symptoms, get that better under control, as well as addressing her cognitive status, with the hopes that she could more meaningfully interact and productively interact with the team about her care and plans moving forward. she had mentioned that she'd had some hallucinations with an opioid in the past. She couldn't recall which one. She thought possibly Dilaudid. She was on a Dilaudid PCA. So we took a strategy of rotating her over to a morphine PCA, which she had previously been tolerating, with a bit of a dose reduction, as well as starting a fentanyl patch for more constant, steady state pain control. And with this, she was using a little bit less in terms of her 24-hour opioid requirement. Her mental status cleared. The hallucinations actually resolved and never recurred. And her pain management was fair. It was a little bit better. There was some room to improve. But initially, she seemed to be, she was having some response with that. Unfortunately, in the coming days, we began having more and more difficulty controlling her pain. So her pain scores now are going up 6 to 10 over 10. In spite of continued adjustments we were making to her analgesic regimen. And she was being followed closely by the surgical team. There was no concern of an additional process going on. This was all felt to be related to her underlying disease. And so between her pain control, her unclear goals of care, and then there was also some conflict around her disposition issues. She very much wanted to return home with her and be in her own home and be with her husband. And her husband very clearly was telling us that her needs were becoming so great that he was having difficulty caring for her by herself. So there were a lot of complications in terms of trying to identify a clear discharge plan for her. So the concept of total pain theory recognizes that the intervention of physical pain alone is often inadequate, and that it's important, it's necessary really to be addressing all of these components, all of these domains to achieve optimal pain control. Having said that, just assessing physical pain on its own is also a very complex process and requires attention to a number of different components and appropriate biomedical due diligence. And so making sure that you have completed a comprehensive pain history, including physical exam and looking at the relevant imaging and tests, all of that, to come up with a pain diagnosis. And for these patients, for our patient, but in general in these situations, often there is more than one pain diagnosis, and she certainly had more than one. Understanding the pain type, is it neuropathic, nociceptive, is it somatic or visceral? Assessing the pain characteristics or the qualities of the pain, as well as pain intensity. And we often will use a VAS scale for measuring that. Looking at the functional impact of pain, as well as the goals of managing pain and the patient's expectations. And are there things that can be clarified in terms of understanding and setting appropriate goals with the patient around their pain management, or are they in need of more education or better understanding about their pain regimen, or how they can engage with that? Looking at the side effects of the regimen that they're on. Are they tolerating it well? Are they having side effects that we need to address or make changes? And then finally, I'll just also add assessing for other factors that may be contributing. And so sometimes we'll see additional symptoms as well that can be augmenting the pain perception or pain experience. So managing other symptoms that might be contributing to the picture, such as fatigue, insomnia, anxiety, depression, and most importantly, cognitive impairment or delirium, where optimizing those situations or providing intervention for that may actually be helping improve the pain situation a little bit as well. And so in this case, we recognize that she clearly had physical pain elements, but it was evident from the first meeting with her that she also had other domains of pain and distress that were present for her as well. So she had threats to the psychologic, the social, and spiritual domains, and after having done our assessment, you can put in a directive way a consult for social work or spiritual care, but being part of a transdisciplinary team, we were able to regroup. We were able to come back and talk to each other about our observations, about our assessments, and then really collaborate in terms of trying to identify a coordinated strategy for best meeting her needs as we were moving forward. And if you're not familiar with this, I just also wanted to introduce the HOPE survey. This is an assessment tool. It's an accessible tool for clinicians to help explore spirituality in their patients. It's a series of questions in different domains that is intended to be a little bit more conversational. And it's not a formal spiritual assessment per se, and it doesn't assume a belief system, but it can be helpful in trying to recognize or understand, are there adaptive or maladaptive, either coping or beliefs or practices that are contributing to this situation, and also trying to identify important sources of comfort or meaning for a patient. So as we continued with Mrs. Jones' care, we were continuing to make adjustments to her pain regimen and address her symptom management. In discussions with her primary team, due to her poor functional status, unfortunately, she was felt unlikely to be a candidate for continuation of further systemic therapy for her disease. Unfortunately, her oncologist, that was her long and trusting provider, was unavailable during this period of time. She had an appointment a couple weeks out, but they were out of town and not reachable for the moment. And this was really creating some distress for her around just having that validation to connect with her personal oncologist. Per the surgery team, there was no further surgical intervention options. And so at this point, we gathered as a team and met with her family along with the palliative care team and as well as the surgical team to try to identify how best to support her and create a path moving forward.
So going into trying to assess for pain for her, we know that evidence shows that there's a lot of psychological risk factors to treating pain, including depression, anxiety, lack of social and emotional support, which was clear here with not having any family members available because of COVID, available in the hospital with her, a sense of self-efficacy and control, maladaptive coping strategies. So those are some of the things that, as Jormain was talking about her assessment, things that she's looking for as a provider to what things are going to impact being able to manage her pain. But then getting further into it with the psychosocial assessment, as a lot of social workers out there might know, we have a ton of different ways to assess patients and how they're doing, how they're coping, and what their life's about and their history and all of that. However, really when it comes to assessing in a palliative care setting, really the best way, and if Lorraine, you could do the next slide here, is a quote from Elizabeth Kubler-Ross, who says, "Listening to the patient's illness narrative with unhurried presence is key to developing a therapeutic presence that fosters assessment of all four domains." And this is really key. This is really what the team does. We sit in the room and we, as you all know, you just listen to their stories. And to be able to come from a perspective where you have Jormain listening for looking at the pain, the physical pain, you have Lorraine looking for spiritual things, and you have me looking at kind of family coping and history. To be able to do that listening in a group and be able to come back together and be able to talk about what each of our assessments were from our disciplines was very powerful with this experience. But for those of you who like to have more tools, Shirley Otis Green has a wonderful psychosocial pain assessment form that really covers a lot of what I'm going to be talking about in my dimensions and the psychosocial dimensions of both social and emotional pain. So it talks a lot about that. And this is found on the City of Hope website. So if anyone's interested in downloading and looking at that, it's easily accessible there. So having talked to, having this family meeting, having talked to the family, having talked to Mrs. Jones, it was really clear that she had had a lot of decline, lot of functional decline, which had led to no longer being able to work. You know, she was this matriarch, she was this caregiver of the family, she was a family planner. All those things had slowly been taken from her as she was needing more care in the home. She wasn't as able to do her activities of daily living. Her husband was having to kind of step up and do a lot more of the things that she used to do, both for herself physically, her own care, but also for home care, and then not even having the energy to be able to do the planning that she used to do and gathering with the family and all of those things. Furthermore, she had this responsibility to her cats that she wasn't able to fulfill what being in the hospital. And then this occurred during the time of COVID and isolation. And so she was not allowed any visitors in the hospital. So very isolated. And all these dimensions of social pain really lead into her emotional pain or psychological pain, a tremendous amount of grief. So you can see the list of all the things we talked about in terms of loss of identity and role and job. And she had confusion. She wasn't coping well. She had a lot of anxiety and fear. As she, you know, each day that went by, there might be another procedure, another thing having to be done to further explore what was possible. And she had so much anxiety around each of these procedures, really struggling with adjusting to this new idea that there may not be treatment available for her. All this led into a lot of depression, existential distress, and demoralization. Back and forth with the sense of, I want to die, I want to be done. And then all this hope for, but if I could just get this done, if I could just do this, if I could just go home, and then the next day I want to die. And as we'll talk about, a lot of these, especially the last few things, really fold into what Lorraine does as well in spiritual care. There's a lot of similarities and a lot of ways that we cross over in talking about her pain. I just want to bring up, even though for Mrs. Jones, these weren't necessarily identified as issues, I do want to bring up some other factors that could really lead to this sense of total pain, stigma. And it was wonderful, Dana, talking about this a lot with the personality disorder talk. There's a lot of stigma, and whether it's coming into the hospital with a mental illness or homelessness or history or current active drug abuse. I mean, all this leads to a sense that people might be treating you differently. Coming into palliative care, coming into the hospital with diseases that are rare. This from a anecdotal perspective of a lot of patients with very rare diseases that feel like they have to explain themselves to their providers, go into the ED and have to like come in with a paper on their disease and explain what it is that they have. You know, we could do a whole presentation on historic and current discrimination and how that leads to a sense of, you know, how that can lead to total pain, but we know racial discrimination, whole history of that can lead to that. Cultural and language barriers, we know there's a lot of disparity in pain and symptom management among populations. So all this really leads to a lack of trust in the same system in which a patient has been entrusted in their care. So just being very aware that these are other factors to look at when we're considering total pain. And then I just want to put out a thing, you know, we are providing psychosocial support or therapeutic support to patients and families who are not necessarily coming into a hospital setting and asking for therapy. So just being really aware that patients are in a vulnerable position. There's a power differential. You know, we the providers are able to provide their meals and we provide their care and their medications and if they need to go use the bathroom. And so there is this power differential that we need to be really aware of. And also the family is part of our client. And so there may be things that the family is sharing with us that the patient wouldn't necessarily share with us. So we tend to sometimes know a lot more about the family dynamics or the history that the patient isn't necessarily wanting to share. And then just being really aware of open charting. And if we're sharing things that the family has shared with us that are potentially delicate, and also just being aware that getting into total pain and going beneath the iceberg, you can get into things that are trauma related, that are very personal and private, and being very aware of how you chart that in a system where everybody who's caring for this person has access to it. So the message really is just obtaining permission and being really transparent with the patient and the family when we're doing work that goes into the more psychosocial and spiritual domains. So next steps, as Jormain was talking about, physical pain was being addressed, treated regularly. We had been holding family meetings, doing emotional support, addressing coping goals of care, beginning to build trust with Mrs. Jones and her family, doing a lot of combined joint visits and some individual visits. She was slowly giving us permission to see kind of beneath that iceberg, beneath the surface of her pain, but she was continuing to express physical, emotional, and spiritual suffering.
Spiritual pain was among the dimensions of total pain that the team identified in our multiple visits with Mrs. Jones. As a team, we strategized throughout our work on this case that assessing for and addressing her concerns of meaninglessness, hopelessness, isolation, and these things could happen not only together as a whole team, but also in combined visits just with social work and spiritual care, and then also in individual one-on-one encounters. My role as a spiritual care provider is to have this notion of bifocal vision in a consultation in particular, which means watching for physical symptoms, watching for breath, for a brow uncomfortable body position, but at the same time, really hearing those descriptions of physical pain. And then again, at the same time, listening for explanations of psychological, social, and spiritual pain. And then again, at the same time, listening for deeper theological and narrative themes. So doing all of those things kind of concurrently, and that leads to a fuller spiritual care assessment. The assessment tool that assessing for spiritual pain really first involves understanding the scope of spirituality for people who are seeking care. And Wachowski and her colleagues define spirituality as that aspect of humanity that refers to the way individuals seek and express meaning and purpose, and the way that they experience their connectedness to the moment, to self, to others, to nature, and the significant and the sacred. And then religion then is a subset of spirituality. It's not the total, but a subset, and it's related to the practices that are associated with organized systems. So when assessing for spiritual pain, I'll use the spiritual care assessment tool, or the PC7, which is a quantifiable evidence-based approach to spiritual assessment as a lens for viewing Mrs. Jones' case. This tool makes use of the STAT scoring system, which goes from 0 to 3, with 3 being the most severe unmet need. And you'll notice in this case that Mrs. Jones had 2s and 3s for most of her scores. So with regard to her concerns about fear about death and dying, this was evident in her swings between expressions of both wanting to die and not wanting to die. She was somewhat avoidant in direct conversation about death and dying, but she would engage in discussions about death and dying in things like completion tasks or wanting to complete her financial paperwork, engaging some in legacy work. And then with regard to treatment decisions, she was very resistant to discharging home with hospice. In conversation that I had with social work and myself, she wondered about she wondered about whether or not hospice was an appropriate intervention for her. And we talked together with a social worker about what hospice care would look like. She really wasn't certain that she was ready for this. It was very difficult for her to make decisions alone in the hospital, away from her husband of 40 years. And this was happening due to COVID. They had never been apart before. So religiously, she defined herself as non-religious. Yet in a one-on-one encounter, she revealed that she had unresolved pain from historical rejection from the Catholic Church at the time of her marriage. She asked for rosary beads and a copy of the rosary prayers. She rejected offers for additional interventions that I had offered up to her, and decided that she didn't have a need to further resolve any of her spiritual pain at this time. Spiritual and religious struggle really can be a significant contributor to a patient's total pain. There are other dimensions of religious and spiritual struggle listed here, where patients may experience, but really weren't present in this encounter. With regard to the need for meaning in the face of suffering, Mrs. Jones had experienced the loss of identity as the family of the planner. This was very, very significant for her. She had a goal of going on a family trip, and she and her husband had been saving for this trip for several years. It was very, very important to her. With regard to the need for integrity, legacy, and generativity, all three of these were important to her, but perhaps the most significant was legacy. The significance of the trip had to do with creating memories for her grandchildren. This is something that we had explored together. She had fond memories of being on trips with her own grandparents, and she wanted to create more for her, with her own grandchildren. And she had a real fear of losing the opportunity to do this. We had talked about various ways of addressing legacy, including creating memory books for her grandchildren and also creating some videos with and for them. She really struggled with the idea of letting go of this trip. And the other legacy ideas, while interesting to her, seemed like a little bit of a thin substitute. This connected deeply with her loss of identity and her loss of feeling like she had meaning and purpose. And so this was truly a spiritual struggle for her. It also represented a kind of unfinished business that was a barrier to making treatment decisions that could positively impact her quality of life near the end of her life. But concerns about relationship really turned out to be among Mrs. Jones' biggest contributor to her total pain. As it was previously mentioned, she was isolated from her husband due to COVID. She was also worried about moving into her son-in-law's home due to the nature of their relationship, which was something we had explored. But the most significant concern was revealed in a one-on-one encounter that came about after we had discussed in morning rounds, sort of yet again, we were discussing the challenges of controlling Mrs. Jones' pain. We had been discussing this on several different days, how difficult it was to manage her pain. And we decided on that particular day that as a spiritual care provider, I would go in and have a one-on-one discussion with her. And as it happened, Mrs. Jones just got into a discussion about the history of some childhood trauma. And she recognized in this encounter for herself, and she was able to articulate for herself that she was suffering from both physical and emotional pain. This was a really important sort of aha for her. And when I ended up leaving this encounter, she admitted that she was exhausted and ready to rest. She looked worn out, but she was comfortable in her body in a way that I hadn't seen her on previous encounters. Her eyes were heavy, her body was relaxed, and she was no longer writhing in pain, and she was ready to sleep. I was using that concept of bifocal vision to examine and assess her in those various different ways.
So I think sometimes when we're in these difficult situations, we can get to a point where you kind of have some anticipation about coming in every day. And I was experiencing that kind of heaviness of coming in the morning and thinking, okay, well, where are we this morning and what happened overnight and how are things going to be? And I came in, sat down with my cup of coffee and turned on my computer, and I pulled up her chart, and it was interesting to see that there was a shift, and her VAS scores were coming down, her pain intensity scores had come down, her opioid requirement looked like it was stabilizing over over the prior 24 hours. And you just get like, okay, that's lovely. And we came into rounds, and as we were just going through our morning rounds and just that process of continual feedback with each other, Lorraine was able to share the significance of the interaction that they'd had with her yesterday. And that was, for us, I think, very gratifying to be able to make that connection and actually see and see some response to that. So in the coming days, she continued to, we continued working on things with her, but she really did have a transition, and while her opioid requirement did seem to be a little bit more downtrending. The important thing was that her pain scores were actually improving, and she was getting more stabilization in terms of the pain scores. She was using a little bit less Ativan. She was a little more alert. Her mental status was improving. She was engaging in her care a little bit more. She was starting to get out of bed and sit up in a chair more. And so with all of this, we were able to come to some compromises or working together in terms of developing a plan to support her. And she ended up going home with her family with hospice support, and we maintained her sense of the importance to her of having that opportunity to meet again with her oncologist, and her sense of hope about being seen by them and potential for more treatment by ensuring that she would continue to follow up as she had planned to with her oncologist, but had the support that she needed to allow her to transition out of the hospital and go home.
So just to kind of wrap up the case and kind of how we see ourselves on this team, there's this great quote from Dr. Ira Byock. It says, "You are on this team because you have all been, in your prior organizations, the one to take the tough shot and successfully sink the basket. You wouldn't be here if you hadn't. Your challenge now is to trust each other enough to hand off the ball to the person best positioned to take the shot, to work as a team instead of as a group of individuals." And I think when I think about the work that the team does every day, especially with these patients that are exhibiting so much suffering, that we're able to trust each other to see who's the person that needs to actually take that ball. And as you can see, Lorraine had the most in this particular case, just having this big breakthrough, and Jormain working really closely with managing her pain every day. It really took a team to help alleviate some of the suffering that this family was going through. And so just to kind of wrap up how kind of our processes help do this and some of the risks. Again, we have these processes we do as Jormain was talking about, going into morning rounds and talking through it, our pre-visits during the visit and the post-brief visit. Just want to bring up a couple different things here. Just that in order to do this as a team, as a lot of you who work in teams know, there really needs to be a lot of team building, trust that you have shared values and goals, and even good leadership within the team. We're continuously defining our roles. We're continuously creating openings for each other, for each other's discipline, continuously looking for not just things for ourselves, but listening for that physical pain or that spiritual pain or the psychosocial dimension of pain, so that we can bring our other folks in to talk more about that. And then just that risk of what we call scope and ego creep. Scope creep being, having done hospice for so long, I've heard the spiel about pain and pain medication over and over and over again, and know just enough to be dangerous. So just also being aware that as we're in these transdisciplinary meetings, that we have experts. And what a wonderful thing that is, that when things come to a medical place or pain medication place, to be able to shift focus on that clinician. And then ego creep. I find that, early in my time, and even now after many years, that sense of wanting to be the person in the group to say the thing that helps relieve the suffering, or say the thing that helps them feel like they're really understood, and just really being aware as we're in these meetings with multiple experts, that it may not be the thing that I say, and the thing that I say may not necessarily be in the best interest of the patient and family, even if it shows me being an expert. And so just being really aware in these teams of experts, not where does our ego creep up? And then finally, again, as Tim and Dana talked about, how nice it is to work in collaboration so that we can support each other, because these are very, very hard patients. These are patients that we think about long after they've discharged. These are patients that unfortunately sometimes keep us up at night or make us think about them first thing in the morning. And so to be able to provide the emotional support, to be able to identify with each other, what are the red flags? Are there any triggers? Are there any countertransference issues that we're dealing with as we're working with these patients? And to have that, post-visit debrief, to be able to get all that out. And to be honest, that happens through all these steps, is that support for each other. which is one of the best parts of team. And in fact, studies have shown that working in teams does help relieve burnout. So, so that's our presentation for you, and we would love to answer any questions. I think we have a couple minutes to do that, maybe 3. If there's any questions or comments or experiences you've all had dealing with the total pain situation.
Don't be shy, everyone. We have as much time as our speakers are willing to give us.
Oh, apologize. The visual analog scale. So just a 0 to 10 scale, pain rating scale. Apologize that I didn't define that more clearly.
I would also love to hear if anybody wants to speak to their team processes. I mean, we have a very specific, kind of 4-step process in providing service, but if anybody else has other things that they do within their team to help with cohesion or communication or support, I would love to hear that as well. Okay, looks like no questions or comments.
Thank you for the comments. Appreciate the comments.
Absolutely, and hope everyone has a good afternoon.
Thank you, everyone, for joining. And just one last thing is, one second. Okay. So we do have our new Cambia Center website up. You can visit our webpage to learn more about the center. And if you are part of the of UW Medicine, you can access a bunch of really great resources at capc.org. The instructions are up here. And I will also include them in the follow-up email. I'm going to upload this recording straight away, and I will send it out along with the evaluation to everyone. I will also link it now, so if you wanted to, you can go in and complete the evaluation right now. Let me just find it. Okay, here it is. And I did get a request for PowerPoint slides. So if the speakers are willing to share those, please email those to me and I will send them out as well. But thank you so much for joining. Fill out the eval now or by the end of September. And we will see you next Friday. Thanks so much, everyone. Goodbye.